discussion for board stuff, but also are pretty practical life examples. So not necessarily super zebras, but things you may actually encounter in your practice. So this first one, I didn't give y'all much history. A 62-year-old woman with abdominal pain, and I don't know names, but I would love to hear your thoughts. So I guess we're just going to have to start on one side of the room and go around. So would you like to tell me kind of what you saw? You can direct how I drive. Here's our low power image. This is
Gastric.
Yep. So we've got a stomach biopsy here. I'll go. It's not great projecting on the screen, so I'll go a little bit higher power. All right.
See the pits, and you can see there's some, I would say, in between the glands, there's some, I guess, active inflammation.
Okay, so especially maybe this area. So it looks busy, right?
Yeah, it looks right.
Yeah, so, you know, your normal stomach biopsies, you look, and your lamina propria should be really open. It should either be pink or kind of pale edematous looking, because you're not expecting that many inflammatory cells to be in there. So it looks really busy, partially because our lamina propria has stuff in it. So if we go a little bit higher power, let's see. Is that, oh, my condenser's already up. It just, okay. All right. Sorry, I'm letting you get in focus.
Again, you can see a lot of these. I guess it's chronic inflammation.
Okay.
So, and then some areas you can see these intraepithelial lymphocytes.
Okay, so we've got some intraepithelial lymphocytes. So kind of like there's, oh, there we go. There's a good one.
And then if it's this busy, like typically in a woman, you look for like H. pylori and stuff like that. So.
Sure. So we would think about a Helicobacter pylori gastritis. Did you find Helicobacter?
No.
Okay, I didn't either. That's good.
I'm not too good at that. So.
What else did you notice?
I guess you see some, maybe this is just a tangential cut, but you see some like fusing of the glands here.
Yeah, you do.
Yeah.
So it's not just busy because of the stuff in the lamina propria. The epithelium looks a little funny too, right?
Mm-hmm.
What do you notice? Or what were there other things you noticed in the epithelium that don't belong?
There's some macrophages.
There's some macrophages. This is a pretty good field. Let me make sure I'm in focus on the screen, I think. So what about things like that? And there's another one. There's another one. There's a lot of mitotic figures, right? A lot of mitotic figures, and not just mitotic figures, although there are quite a few of them. What about things like these dark dots? What's all that dark? Yeah, apoptotic debris. So we've got a lot of apoptosis, and we've got a ton of mitotic figures. So what do you think about that?
Maybe some kind of atypia neoplasm.
All right, so that was the question. This was a consult case that came in, and it was, what is this? Is this cancer? So what is this? Is this cancer? Anybody?
This is mitosis, is like a ring form.
They are ring form mitoses. That is excellent. So these are ring form mitotic figures. Let's find a good one. I mean, not all of them, right? Some of them just look like plain Jane mitotic figures. Now that I've said, yes, they're ring forms, but we're going to find a good one. Let me back up. It's so dark for me when I get that close to it. Well, you're just going to have to trust me that there are some really good ring forms down in here that I can't find right now. As soon as I stop looking for them, I'll find one. So what do ring form mitotic figures make you think of? Why is that important? Medicine induced. What kind of medicine?
It's like
Taxols. That's excellent. What else? And colchicine. Perfect. So is this cancer? What's your answer? No, it's not. There's a good one. There's a good ring form. See how it's circular? Oh, it's not on the screen. Oh, good job, Meredith. All right, come on. Get it on the screen. How about now? Yeah, there we go. A nice little circle mitotic figure. Y'all just yell at me if something I'm pointing to isn't on the screen. Okay, So important things to know. This is something that could cross your desk, right, as a GI pathologist. This was an older lady. She had some stomach pain. This is a very busy biopsy. On low power, we've got that chronic inflammation, but it's not just the chronic inflammation. The epithelium's not quite right. The cells are a little jumbled. They're bigger and reactive looking. When you get down there, you've got a lot of mitoses and you have a lot of apoptotic debris. And that is classic. Those ring form mitoses and the background apoptotic debris are classic for two types of medications. You were exactly right. So taxanes or Taxols. So those are chemotherapeutic drugs. And then your other one's going to be colchicine. So they both work the same way. I'm just going to leave this sitting right here on a nice view and talk. So they work in the same way. So your Taxols and your taxanes for boards, this is something that could come up. They bind microtubules, and so they prevent microtubule depolymerization. So practically what that means is your mitotic figures, when they're trying to pull apart, they can't. They get stuck in metaphase because the microtubules can't depolymerize. And so you see these ring mitotic figures because they're trying to pull apart and they can't. So that's where we get the ring mitotic figures. So then under the scope, you not only see the ring mitotic figures, but also eventually those cells will just give up and die. And so you see all the apoptotic debris. So you see both. You see the increase in mitoses or mitotic figures, some of which will be ring forms, and you see all the increased apoptotic debris. And like you said, it also looks very reactive. The cells are big, but the nuclei, the chromatin's open. So there's atypia, but it's not like malignant atypia. It's more reactive atypia. So that's what you're going to see in a taxane or a Taxol, and that's a chemotherapeutic agent. It's typically for ovarian, for lung. I think also sometimes for breast. I'm sure if I'm wrong, someone on YouTube will correct me. And so in this woman, we found out that she did, in fact, have an ovarian malignancy. She had just gotten a dose of her chemotherapy. You can see these changes for up to about 2 weeks after your dose of chemotherapy. So in this patient, this is a normal response to the chemotherapeutic agent that she received. So you don't have to worry about it. Our answer back to the consultant was no, this is just reactive. This is due to her drug. It's a drug-induced change. You don't need to worry about it, not malignant. Now, what about colchicine? It's the same mechanism of action. It binds tubulin and prevents your mitotic figures from depolymerizing. The problem is, though, in colchicine, when you see this, that's because your patient has too much colchicine. It's a toxicity. So if you see this in a patient who's taking colchicine, you need to call the clinician because they have colchicine toxicity. And so that's actually one of the emergencies that you might need to call. So if you don't have that history on a patient, if you've just got, let's face it, most of our gastric biopsies come with like abdominal pain. It's the history, right? And you don't know what the patient's taking, and you see these ring mitotic figures, you see the increased apoptotic debris, you need to think, this looks like it could be a drug. I don't know what drug the patient's taking, so I better call the clinician and make sure they're not on colchicine for their gout, because if so, the dose needs to be decreased. They need to stop it. Patient has toxic levels. So those are good boards questions that can come up on taxanes and colchicine. And you don't have to write down everything I say. I have a handout that I can give you at the end that has all this stuff in it. Questions about number 1?
What about location? Is there a difference between the locations as regards colchicine and taxane?
No. Nope. Similar mechanism of action, similar findings in your GI biopsies.
That's a question with colchicine toxicity. So I noticed like the inflammation was mostly chronic. How soon after the toxic levels were raised?
That's an excellent question, and that I don't know the answer to, quite honestly. I don't know how long after someone reaches a toxic level of colchicine do you see these findings, and I don't know if that has anything to do with the type of inflammation that you see. I do not know. That's a good question, though. I don't know how you would study that, but I'm sure someone out there has looked at it. Right.
My thinking is, how long the patient could have been on it.
Sure.
Toxic.
Sure.
Yeah. Without pain,
right. Yeah. No, that's a really good question, and I'm sorry, I just don't know the answer. I do know for the chemotherapeutic agents, it's about 2 weeks, but I don't know for the colchicine. All right. Do I have a clock somewhere? Okay, 10 minutes. That's about right. All right. So number 2, this is a 55-year-old man with abdominal pain. All right. So let me just make sure I'm sort of on in focus. Can we even go farther out? Oh, we can. Excellent. I like the 2x for this one. All right. So I've already picked on the nice doctor to my right. So it's somebody else's turn. I'll either point or someone can just tell me what you're seeing on here.
We have like a submucosal spindle cell lesion with vascular proliferation.
Okay, so where are we?
It's stomach, so it looks
Yeah.
like antral mucosa.
Yeah, so we're in the stomach, and you're right, we have this lesion. What strikes you about our lesion? Anything.
The prominent vascularity, and
Okay.
on closer examination, on higher magnification, you do see a lot of eosinophils.
All right, so we've got some vessels. We've got quite a few eosinophils in the background. Anything else? Anyone?
It's very mixoid looking stroma.
Yeah, so mixoid, we could use the word mixoid. I'm always hesitant to use the word mixoid because that is going to bring up a whole mixoid soft tissue differential. It is loose. It's edematous. It's pale. And what are our lesional cells look like? I'm sorry, I'm going to cough.
Okay.
Apologize to people just listening.
Some inclusions.
Okay, so we're on 20x. That's pretty good. So we have all these little kind of monotonous, kind of unremarkable looking spindly cells. Oh no. Can't have a coughing fit in the middle of my lecture. Okay, so any ideas as to what you would want to call this lesion?
I think one thing we can consider is an inflammatory fibropolyp.
Okay. I like that consideration. Did anyone else have anything on their differential? All right. Fine. It's an inflammatory fibroid polyp. I'm so sorry, guys. So I think inflammatory fibroid polyps, the first thing I notice when I even just look at the 1X slide is that it's very pale, right? Like you look at this and you're like, I have a lesion. It's pretty big and it's very pale on 1X. And when you put it down, this is our 2X view. It's also very, very pale. And that's because it has this loose edematous stroma to it. It is, as you noted, submucosal based, which is so important when you're dealing with lesions in the GI tract. Where the mass is kind of based or coming from is super important for your differential diagnosis. So the fact that you recognize that, so here's our lamina propria and epithelium. This looks like our muscularis mucosae that's been kind of split. And then here is the bulk of our lesion in the submucosa and kind of crawling its way up. So that's very important because that's where inflammatory fibroid polyps live. They live in the submucosa. They become large. They're most common in the stomach, which is where they really just, especially when they're antral based, as you noticed, Emilio, that this one is antral based, they get polypoid and then they flop and they can cause gastric outlet obstruction. And so people can have nausea, people can have abdominal pain. It's not because they're doing anything nefarious. They aren't malignant. They're just getting in the way. They're just, it's kind of like a mass effect. Now, I've been calling this a lesion because for a long time, we thought that these were just reactive, myofibroblastic, fibroblastic type proliferations, reactive proliferations. But we now know that these have, most of them have PDGFRA mutations. So they probably are a benign neoplasm. A benign neoplasm. But as far as we know, they have no malignant potential. And so that's kind of something, again, that could show up on your boards, PDGFRA mutations, but completely benign. You just excise them, and the patient does fine. So diagnostic things, besides being pale and having that loose edematous stroma, as Emilio pointed out, we have these vessels. This isn't the best. People often talk about onion skinning around vessels. I mean, if I squint, maybe I could pretend there's some onion skinning in this one, but there's really not good onion skinning in this example. But the vessels are prominent. They do stick out at you, in part because the surrounding stroma is so edematous that the smooth muscle of the vessel walls is actually dark. They also have the kind of unremarkable, monotonous looking spindle cells component. So, you know, these guys, they aren't even super spindly. They're just, but they're not epithelial looking. They're not epithelioid. And then also you have all these eosinophils in the background. So those are all really the submucosal base, the pale stroma, the spindled cells, the prominent vasculature, the eosinophils are all diagnostic of an inflammatory fibroid polyp. Now, if you wanted to stain one of these, I have another example to show you. If you were unsure and you wanted to stain one of these for some reason, they will stain with CD34, but you don't have to do. Here's another nice example. I think this one's also gastric. Let's look. Yeah, there we go. So here's another one. So again, we're in the antrum, and they saw this polyp, and then you have this very pale. They didn't get as much of this one because they didn't get as much submucosa, but you have this very, very, very pale, like you guys said, almost that bluish myxoidy look, edematous stroma. You get closer to it, you have very monotonous. These even have spindlier, I don't think that's a word, more spindled cells, lots of eosinophils. And in this one, we don't really have much of the lesion, but you can tell that there would have been prominent vasculature if we had gotten more of it. But again, submucosal base. So spindle cell lesion in the stomach, what's your main differential if you don't have a gist, right? So you're going to think about a gist, but where does a gist live? What layer of the stomach does a gist come from, or of the intestine, I should say? Where's it going to be based? Oh, come on. You guys know this. Where's a gist come from?
Interstitial cells.
Right. So you've got the interstitial cells of Cajal. Where are those? They're not in the submucosa.
They're right above.
They're in your plexus, in between your two layers of your muscularis propria, right? So if you have a gist that's based in if you have something that's a gist, the bulk of that mass is going to be arising from your muscularis propria. So when your endoscopist looks at it, they're going to say, this seems to be a deep lesion. And sometimes they can use ultrasound and they can say it's based in the muscularis propria. And often when they take a mucosal biopsy, which this is, we won't even get any of it, or you'll have a few little spindly cells if it's big enough and it's pushed its way up. But the bulk of that mass is going to be in the muscularis propria. This is another inflammatory fibroid polyp. I think this one was in the duodenum. Yeah, here we go. Small intestinal mucosa over here. And you can see again, so here's our small intestinal lamina propria epithelium. Here's our muscularis mucosae. Here's the bulk of our tumor, right? And again, this lesion, very, very pale. So pale on low power. Very edematous. You get down there, you do have all these prominent vessels. They're prominent here because they're still filled with the red blood cells. So you do have good vessels. And tons of eosinophils. And again, those kind of spindly cells. And these spindly cells look even different from the past two inflammatory fibroid polyps that I've shown you. So, so you have to put everything together. You can't hang your hat on just one diagnostic criteria, but submucosal base, spindly cells, eosinophils, prominent vasculature. If you see onion skinning, that's great. That probably would be a picture they could show you on your boards with some nice onion skinning. If you're thinking about a gist, it's going to be deeper. It's going to be muscularis propria based. The cells can be spindly. They're going to be very, 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 very monotonous. They don't tend to have that dense eosinophilic infiltrate. And in the stomach, especially, you're going to be more likely to, or you can be, see epithelioid gists. And so you may have epithelioid cells as opposed to a spindle cell lesion. But location is super important for those. All right, so that was case number 2. Case number 3. This was a 40-year-old man with stomach polyps. And this is kind of unfair because I didn't give you all the history, but again, you probably are never going to get all the history either. So this is just like real life. All right. Next person who hasn't talked yet. I will just go ahead and point out to the people listening that this is obviously someone who's had a stomach resected. So that should give you some clue as to what's going on in this tissue section here. So what are we looking at? Where are we, first of all? Well, we're in the stomach. Are we really in the antrum? No, because we've got our, we've got accentic mucosa. That's okay. I was on 2X. So we've got accentic mucosa. What's going on up here at the surface? If you just had this, what would you call this? A fundus gland polyp, right. So let's just look here. Let's enjoy our fundus gland polyp. So we have these dilated we have these dilated spaces, and they're lined by this flattened accentic mucosa. And then you also have areas that have the more foveolar type mucin. We're in accentic mucosa, so having a fundus gland polyp is normal, almost. I mean, you get fundus gland polyps in up to 5% of your GI biopsies, and they're totally benign. But this one's been resected. So did you find anything, leading question, did you find anything that you thought, I bet that's why they resected this lesion, besides the fact that it's just huge? What do you think about an area like this?
Yeah.
Crowded.
Looks more crowded.
More adenomatous.
Yeah, so it looks, so you're saying things like atypical, more adenomatous. I think that's all right. So instead of having those nice dilated, flattened glands, you have these. The cells are larger. They're much more crowded. They're kind of rounding up in some areas. They're piling up on top of one another. Some of them still look like they're trying to obey a basement membrane rule, but some of them definitely aren't and are crawling all over each other because they're proliferating. The nuclei are longer in some areas. They're a little bit more hyperchromatic. Even though we're at the surface, and I'm sure that some of this is plane of sectioning, the architecture is more complex. The glands are back to back to back. There's no lamina propria in between them. If we look back over here, look at all that nice edematous lamina propria separating out our dilated glands, as opposed to here where they're back to back to back. That's always, I think, very helpful to me in upper GI dysplasia, that lack of a lamina propria. You start to lose it. Every place that the cells look funny, the cytologic atypia, I'm getting architectural atypia as well. So this is a fundus gland polyp that actually has dysplasia in it, and high-grade dysplasia at that. So it's not just that we had a little bit of low-grade dysplasia, but we have this complicated architecture, much larger cells. I mean, who knows where one of these glands, one of these pits begins and the next one ends. And so we have a fundus gland polyp that here is benign and here has transformed into something dysplastic. So what, in this 40-year-old man, what could he have? What would you think of in this patient? You would probably already know this, but if you didn't, who could this happen in?
You said that there are polyps, right?
Mm-hmm. Multiple.
Yeah, so part of syndrome, I guess.
APC.
There is some, huh?
Yeah. So the FAP, so familial, y'all are both right. Familial adenomatous polyposis, which has the APC mutation. Exactly. And so patients so fundus gland polyps themselves are super common. Like I said, in some series, it can be up to 5% of gastric biopsies. You can see fundus gland polyps because they're reactive. People get them they've been on PPIs a lot, or you just see them all the time, and they're totally benign and they're small, and clinicians biopsy them just to confirm the diagnosis that it's a fundus gland polyp and that they don't need to worry about it anymore. Now, in patients who have FAP, their fundus gland polyps actually aren't reactive. They're actually neoplastic. They carry the same APC mutation that defines their disease, and they can become dysplastic. And so anytime a clinician is surveilling one of their FAP patients and they see one of these big fundate gland polyps, if it's a centimeter or larger, they excise it, in part because they can become neoplastic in this population, or dysplastic, I should say, in this population, and can progress to frank carcinoma. Now, is this uncommon? Yes. Can it happen? Yes. And so I just want to point out to you that you can see dysplasia in a fundate gland polyp. It's most likely going to be in your syndromic patients. Now, if you see a fundate gland polyp that's sporadic in somebody who has no risk factors for anything, and it's just somebody who's on a PPI and they have a fundate gland polyp, sometimes the surface can look kind of funny, either reactive, and every once in a while you'll find one that does have what people consider to be low-grade dysplasia. But in a sporadic setting, a fundate gland polyp with low-grade dysplasia basically does nothing. It does not progress. There are case reports of them progressing. I take those with a grain of salt. Fundate gland polyps in a non-syndromic patient are sporadic and pretty much benign, and then benign. So if you see something like this in a patient that maybe they don't know it's syndromic, maybe that patient has an attenuated form or they're the index case. So you would want to tell your clinician, hey, I really think this patient's got something else going on. Let's see, is there anything else that I wanted to tell you about FAP? Oh, a good boards question. So, you know, the people with FAP, all patients with FAP will go on to develop colorectal carcinoma if you don't take out their colon, right? They just have innumerable polyps. They eventually, one of them is going to become malignant. So most of those patients have their colon taken out. But the second most common type of colonic neoplasm or intestinal neoplasm, GI neoplasm in an FAP patient, anybody know what it might be? This is one of those questions like they'll put on your boards just because. It's one of those like statistical things. It's a duodenal adenoma. So the second most common kind of neoplasm that you'll see in the GI tract of an FAP patient, they're going to be full of tubular adenomas in their colon. That gets taken out, and then they get upper GI surveillance because they have very commonly duodenal adenomas. And obviously, you can't just take out the entire intestinal tract of these people. So they're surveyed that way, and they'll have duodenal adenomas. They also can have fundate gland polyps. They can also have other types of adenomas in their stomach as well, but less common. All right, I am probably going to get through 6 of these, which is what I suspected. All right, 4. This is a 55-year-old one with abdominal pain. Did y'all see a pattern in my histories? Abdominal pain, abdominal pain, abdominal pain. You can see what gets written on our clinical. Oh, this is probably my favorite. Okay, who wants to? I know, y'all are like, why? I'll tell you why. Okay, who would like to describe what we have here? We're again in the stomach, yes?
I can try.
Go for it.
So I think it looks like antral mucosa here.
It does look like antral mucosa here.
It's very busy.
It's very busy.
And the busyness, like it's more kind of a patchy thing. So it's like at some places it is scattered, somewhere it is like.
I'm trying to get in focus. Okay, there we go.
Localized. So there are some small nodular areas of inflammatory cells. Like here.
Like here, it's really dense.
This is more dense.
Mm-hmm.
And there are some small foci here and there.
Here it's quite inflamed.
And these cells on higher part we go.
Sure.
They look mostly lymphoid cells.
Mm-hmm.
I don't want to say lymphocytes directly, but it looks very lymphoid and monotonous to me.
Okay.
So in some areas there is admixed plasma cells.
Yeah.
Some of them.
There are also plasma cells and occasionally.
And there are some eosinophils here and there.
Okay, so we've got a mixed inflammatory infiltrate that's dense in some areas. It's kind of patchy. And you said something very important. You said that this looks like antral mucosa.
Right.
What do you think about this piece?
This is fundate, like
okay.
Area. Yeah. So that is little weird. So that, this is what is. So number one, it is not, it looks an inflammatory condition, and we have intestinal metaplasia at some
We have
places.
intestinal metaplasia.
There is some probably atrophy of the glands at some places.
Okay.
That is something that.
And you say that because we've definitely got areas that just
Mhm.
don't have gastric pits
Yeah.
at all. Our our epithelium just is missing.
Yeah, I was looking for intraepithelial lymphocytosis, which is not there. So
Okay.
lymphocytic gastritis will be out. And,
Okay.
I was also looking for lymphoepithelial lesions, which was suspicious at some places, but I would ignore it.
I would also ignore it.
But the fact that we have this atrophic gastritis at some places, and we have this mixed inflammation going on. So, and there is an inflammation which is also involving the fundic area. So I would think of autoimmune gastritis.
And you would be right. So this is a good case of autoimmune gastritis. Okay, so terminology for autoimmune gastritis is somewhat controversial. You will hear it called different things. I was taught that this is called AMAG, autoimmune metaplastic atrophic gastritis. It's long, but it's descriptive and tells you exactly what you're seeing. It's an autoimmune process. You are going to have metaplasia, intestinal, and sometimes pancreatic metaplasia. Atrophic, you have atrophy of your gastric epithelium. So we have just complete loss of some of our gastric epithelium here. These cells, these poor little cells right here are just completely dying off. Please tell me that's on the screen. Oh, excellent. Atrophic. And we have an itis, right? Like there's this pretty striking on low power mixed inflammatory infiltrate that really is in there. And you really do see that some of the pits just look like they're dying, like you said. So not really a true lymphoepithelial lesion, but definitely an itis that is destroying glands. So other people have called this just plain old chronic atrophic gastritis. Some people just call it plain autoimmune gastritis. So you'll hear it called different things. But the most important thing is that you recognize it, that this is just not chronic inactive gastritis, okay? You're going to do your patients a disservice if you sign this out as chronic inactive gastritis, because that tells the clinician, I don't know what's going on. Maybe it's a medication. Maybe they ate something. Maybe they're getting over an infection, right? Which is not true. You know why this is happening. It's autoimmune. So what is happening? What is being destroyed in autoimmune gastritis? Parietal cells, exactly. So the patient has antibodies that specifically target the potassium, the hydrogen potassium pump that is at the luminal surface of your parietal cells, and that produces your gastric acid. So it attacks that pump, your parietal cells die, giving you the atrophy of your mucosa. So the interesting thing about this case is that this is body, and this is body. All of these are from the same area, but they look very different. So you get this antralized picture. You might think that this is antrum, but when you get down there, you realize there are some parietal cells. The reason it looks like antrum is because the parietal cells are being destroyed. The oxyntic mucosa is being destroyed. So you have loss of your parietal cells. So that's the autoimmune part. Your parietal cells produce your gastric acid, which is important for iron absorption. You have to have an acidic environment in order for your dietary iron to become the kind of iron, and I always forget, I have to look it up, that you can absorb. And so the first thing that happens to these patients is they actually get an iron deficiency anemia. And so that may be the first thing that people notice. Hey, there's an iron deficiency anemia. They're not bleeding. They just can't absorb their dietary iron because they aren't making enough gastric acid. As your gastric acid decreases, the G cells, the gastrin-producing cells that are in your antrum, rev up production because they're trying to tell the leftover parietal cells, hey, we need more gastric acid. So people will have hypergastrinemia. They'll actually have increased levels of circulating gastrin, but not a gastrinoma. The other cells that ramp up production are the histamine, the enterochromaffin-like cells that are actually in your your fundus in your body. And histamine also is being produced to try and act on your leftover parietal cells to say, hey, we need more gastric acid. And so you'll have enterochromaffin cell-like hyperplasia in your body and your fundus that you can see sometimes. I'm not really 100% sure I see good. From what I can tell, these may be little nodules of ECL cell-like hyperplasia. And so you can see that. And then, let's see, I was on track to tell you one more thing. I have another slide, though. I brought some other examples so that you can see. So your histamine cells rev up, and so you can have ECL cell-like hyperplasia. What else do you see in AMAG? Oh, right. I haven't told you why you get pernicious anemia yet. So once you lose enough of your parietal cells, you don't make enough intrinsic factor anymore. Your parietal cells also produce your intrinsic factor, which is necessary for absorption of your vitamin B12 in your ileum. And so if you don't have your intrinsic factor, you don't absorb your vitamin B12. And so eventually you get a pernicious anemia. So we always think about autoimmune gastritis with pernicious anemia, but that's kind of a late event. So these people can have gastritis and be iron deficient and then eventually get a pernicious anemia. Can we treat this? Okay, before I ask that question, let me back up. Here's another AMAG, same thing. Lots of inflammation, intestinal metaplasia. This looks like antrum, but it's not. Same thing here. Lots of inflammation, intestinal metaplasia. Looks like antrum, but it's not. This is actually either body or fundus. The oxyntic mucosa has just been killed off, has atrophied. Same thing here. Same thing here. This is all body and fundus mucosa. How could you tell? This is a good question. If you got this and you're like, wow, they just say stomach. I think this looks like autoimmune gastritis, but I know that that should impact my body and fundus and not my antrum. But this all looks like antrum. How could you know? What's a stain you could do to determine if you're looking at antrum versus body fundus? Gastrin, right. And so if gastrin's negative, you know you're in body fundus because you only have G cells in your antrum. Here's yet another one. Can y'all tell I like AMAG? I collect them. Every time I see one, I'm like, oh, pretty. And I ferret the slide away. So here's another one. So early, right? So you've got some inflammation, some destroying crypts, or not crypts, I'm sorry, pits here. You still have some of your oxyntic mucosa, but you definitely have this kind of full thickness inflammation. You, of course, would want to rule out an H. pylori because it's top heavy in this section. But then in other places, you have this. Looks like antrum, probably isn't antrum. Full thickness, inflammation, and I think somewhere on this slide, maybe that one didn't have metaplasia. Things that are commonly seen in autoimmune gastritis, people, because the mucosa is damaged, people will get hyperplastic polyps. Hyperplastic polyps occur in damaged mucosa, and sometimes that's a clue that you have an autoimmune gastritis because sometimes the clinician will only diagnose the polyp, and then kind of on the edge, you'll get just a little bit of quote unquote normal mucosa. And you look at that and you're like, that's not normal mucosa. That's way too inflamed. Where are all my oxyntic mucosa? They tell me I'm in the fundus, and this certainly doesn't look like fundus. I don't have enough oxyntic mucosa. Maybe this patient actually has autoimmune gastritis, and I have the hyperplastic polyp because of the damaged mucosa. Perhaps I should raise that possibility to my clinician. Now, we can't treat this, right? There's no magic drug to give someone to make their autoimmune gastritis go away. You can give them iron supplementation and vitamin B12 supplementation. But to me, the importance of naming it is for that patient, right? You have patients that I have seen outside biopsies, and they're just called chronic gastritis, chronic gastritis, chronic gastritis. They don't know what's wrong with them. Their stomach hurts, and they keep going back, and they just keep being told that they have chronic gastritis. And so naming it lets that person know that they actually have a disease. They have autoimmune gastritis. There's something actually wrong with them. It's not all in their head. It's not an unknown entity. They do need to be followed because, as with anything, a chronic inflammatory state, they're at risk with that intestinal metaplasia for going on to have adenomas and dysplasia. They're at risk for type 1 carcinoids because of their constant hyperplasia of their ECL cells. And those type 1 carcinoids can usually just be shelled right out. They don't need a gastrectomy for those. And so it allows the clinician to know, I need to survey this patient for specific things. And it allows the patient to know, I actually have a disease and I need vitamin B12, and it's not just that my stomach hurts all the time. So I just think it's important as pathologists, one of the powerful things we can do is communicate, and we can actually put a name to things. And so, no, it's not curable, but I do think it's important to be able to name for these patients what they have. More common in patients who have other autoimmune diseases. So you often see it, somebody already has autoimmune thyroiditis, and then they have AMAG. What else? I can't think of another autoimmune disease off the top of my head, and I'm running behind, so I'm going to stop now. But I have everything I just told you is written down in my handout. Let's see. So this is 5. This is a 45-year-old man with stomach polyps. Oh, I love this one too. All right. Who would like, so here is our accentic mucosa that was conspicuously lacking in our last biopsy. And then here is not accentic mucosa. So who would like to describe this gastric polyp? Somebody that hasn't talked yet about a slide. I will point at you. All right, Mr. Green Shirt. What does this polyp look like to you?
So it has varying size glands.
Mhm.
Some of them are dilated.
Mhm.
Some of them have, I guess, another. They look very complex and have a penciled nuclei.
Okay.
So I mean, is this dysplastic?
Well, keep going. Keep telling me what it looks like.
Sure.
How would you describe the cytoplasm?
There's abundant cytoplasm.
Okay.
It has I guess, apical vacuoles.
Mhm. Is it pink? Is it purple? Is it amphiphilic?
Don't know based on the color here.
Yeah, okay,
Kinda
fair.
amphiphilic.
It is kind of amphiphilic. That's true. The screenshot, unfortunately, is not exactly the way it looks under my microscope. True. And so you're right. The nuclei all seem to be sitting along this basement membrane. They are back-to-back glands, which I told you earlier always is like a way that I think about, ooh, that's probably dysplasia in in an upper GI biopsy. They do have abundant cytoplasm. People have described this as ground glass cytoplasm, whatever that means. I always wondered that for radiologists too. Mm-hmm. They always talk about ground glass opacities. I never knew what that meant, but I am perpetuating the term of ground glass cytoplasm in this entity because I think it is descriptive of the tinctorial quality of the cytoplasm. It doesn't look like the cytoplasm you see in an adenoma, right? It looks a little different. Anybody have a name or want to throw out what they think that this entity could be? I just told you it's not a typical like intestinal type adenoma because I just told you the cytoplasm doesn't look right for it. So that takes one thing off your differential. Oh, nobody?
This again, you said that patient has multiple polyps, right?
Uh-huh.
So again, it's part of some syndrome, number one.
Could be.
Yeah, and age is 45.
Mm-hmm.
So I was maybe like thinking if it is part of something like Cronkite Canada syndrome or something like that.
Oh, that's an interesting thought. So it could be part of a syndrome. You can see these in patients with familial adenomatous polyposis, which is probably why I said he had multiple polyps.
Gardner syndrome or something like that. Because there is ATP also, as you say, in the top, right? Like low grade.
Yeah. So yeah, I think that this is probably has, I think by definition, a little bit of atypia to it, a little bit that it is a dysplastic lesion. So this is called a pyloric gland adenoma. Okay. So these have been described, I think they were first described in the German literature, actually, back in like the 70s and 80s, as this lesion that shows up in the stomach, but also in the duodenum and in the gallbladder. You'll see something very similar. And they all have this look, the same look, no matter the site. The cells, for the most part, should be columnar cells with abundant this amphiphilic ground glass cytoplasm. The nuclei respect their in a normal one respect their basement membrane. They're usually small to slightly columnar looking, but not cigar-shaped adenomatous, right? And the glands are back to back to back. And these show up in the stomach, in the gallbladder, in the intestines. And so if you start to get one that starts to look a little, let me see if I can find a good spot. This one is pretty much low-grade dysplasia, despite the back-to-back architecture. When they do become dysplastic, the nuclei actually get bigger, rounder. They start to lose their prominent cytoplasm. The architecture can get more complex. And so those need to be completely excised. Regardless, pyloric gland adenomas probably should be completely excised because they can have high-grade dysplasia and progress to an invasive carcinoma. Now, like I said, pyloric gland adenomas can show up in patients who have familial adenomatous polyposis. They can also show up in patients who have autoimmune gastritis. You can see pyloric gland adenomas, just like you can see intestinal type adenomas, hyperplastic polyps. You can see pyloric gland adenomas. I have another one here. This one's a big one. This one's a big one from the duodenum, I think, is where it was. Let's back way up. Yeah, right. So here's our resection margin. Yeah, and we're in the duodenum because we can see that we've got Brunner's glands. And if you go up, here's the same lesion, right? Let's go on a little bit higher power. This one's a little bit pinker. We used a little bit more eosin in this lab. But otherwise, looks exactly the same. I could switch out these two, and they would still have the same abundant pinky purple ground glass. It's a little bit opaque, but almost like you could see through it. Cytoplasm. Cells mainly respect the basement membrane. Mainly columnar, like low columnar to medium columnar type cells. The nuclei are a little bit not quite cigar shaped, but not perfectly round either. Back to back to back to back glands. If you saw an area where the nuclei started to get really round and a little bit more atypical looking, you would worry about high-grade dysplasia. And this one was huge and was probably causing an intussusception or something. And they found it and they excised it completely. Down here's our resection margin. So looks exactly the same as the one in the stomach. Pyloric gland adenoma can show up in FAP patients. These are the kinds of changes. I knew I had it on here that you don't really want to see in a pyloric gland adenoma. See how they start to lose their polarity and the cells get bigger and rounder? I think dysplasia in a PGA is really hard because it almost looks more like reactive atypia. But in a pyloric gland adenoma, this is what you don't want to see. It almost looks reactive atypia, but it's not reactive atypia. This is like progression of dysplasia. These round nuclei, prominent nucleoli, loss of polarity, all of that's badness in a pyloric gland adenoma. So you want to look for dysplasia in these. Yeah, so these were recognized by the WHO officially in 2010. So now they're in the WHO Blue Book, but they've been known about since the 70s, 80s.
How often you see these squamous morioles?
In a PGA, I don't know that you see squamous morioles in a PGA. You'll see, when I think about squamous morioles, I think about colonic, like big tubulovillous adenomas. You can see squamous morioles, which I tend to be neither here nor there. Sometimes people will say they're associated with high-grade dysplasia, but they don't necessarily mean much.
In gallbladder,
it's entirely possible that in the gallbladder they may have squamous morioles, but the ones in the stomach and the duodenum, that's not something that I even think about or that I even think I've seen. But again, these aren't very common lesions. It's something that could come across your desk though, and so it's the kind of thing you want to be able to recognize that it's not just an intestinal type adenoma or a foveolar type adenoma, but that it's something that they should go back and they should probably get completely out of the patient. So it's one of those things that it's not common, but it can come across your desk. And it's another one of those that the boards could give you like a single shot view and be like, what is this? You know, so because they need those kinds of lesions, right? The ones that they can just give you a one picture view and ask you what it is. And there's only so many things that you can do that, because a lot of times you need to have multiple views of something. But that's one I think that we could just do. Okay, I have 10 minutes to do 2 slides. We're never gonna make it. I can make it.
Yeah.
Okay, so this is number 6. This is a 35-year-old woman with breast cancer. Oh, this is a good case. Okay, I haven't looked at these slides in a while, so who would like to tell me what we have here? Anybody can describe what we are seeing in this particular field.
So we have gastric biopsy showing what looks like oxyntic mucosa.
Right. Okay. This is oxyntic mucosa. I'm just going to help you and say this is normal. Now I'm going to move, and you tell me when it stops being normal.
It's still normal.
Okay.
It's a little edematous, but
Yeah, but okay, right? Like if you just had this biopsy, you'd be like, normal, next case. Good. Great. Okay, still normal. Oop-a-doop-a-doop-a-doo.
Yeah.
Oh, not normal. Okay, what's not normal?
So there are multiple signet ring-like cells.
Mm-hmm.
around the focus.
Yep. Yep, right there, right? So we have, I don't know how many tissue sections are on this slide, 6 or 7.
Yeah.
And we have this one biopsy that has these super seeky signet ring cells just up here, just hanging out in the lamina propria. Would be so easy to miss them. Now she's 35 and she has breast cancer. So there are a couple things to consider with this case. What would you consider? Are you just going to say, oh, cancer, next case?
Medicine, medication, chemotherapy.
No, these are true signet ring cells. These are real. I'll give you, they're real. They're real cancer cells. I'm just wondering, are you going to say gastric cancer? Are you going to say metastatic cancer? Are you just going to say cancer and make the clinician figure it out? What are you going to do?
You probably need to work this up.
You probably need to work this up. Okay. So she's 35, so she's quite young to already have a breast cancer, although not unheard of. What sort of immunos might you want to do to try and help you?
Ovarian.
I will do a CD68 also.
You would do a CD68 also because you think that I'm trying to trick you. No, these are not foamy histiocytes. They're real. I promise. You could do a CD68, but it would be negative. So these guys they've got the real nuclei that are shoved over to the side, expanded by this mucin vacuole. So, and I know they don't, they're showing up all right on the screen.
Yeah.
So these are real. So you could do a CD68, but it would be negative. I mean, that guy, that's a dark shove to the side nucleus. These are signet ring
So
cells.
CK, of course, then maybe hemoglobin.
Okay.
Or
So you could do
GATA3.
a breast panel, right?
Yeah.
So you could add like an ER, a PR, a mammoglobin. You could do a GCDFP.
CK720.
Now, CK7 is not really going to help you differentiate between gastric and breast, right? Because you would expect both to be positive.
Yeah.
But if you had a couple CK20 positive cells hanging out down in there, that would help you think more gastric than.
CDX2.
Or CDX2, right. Why would I even be thinking that this could be a primary gastric carcinoma in this patient, though? She's only 35. What could she have?
BRCA.
BRCA and stomach doesn't really go together. Good thought, but no. It's a different syndrome, a different mutation. Okay, that's an excellent thought. So yes, gastric cancers are more common in people with Li-Many, the P53 mutations, but this one's specifically for breast and stomach. No. Ooh, breast and stomach. Y'all don't know. Oh, excellent. All right. Have y'all heard of the CDH1 mutation, ECAD-Huron mutations? Okay, so CDH1, it's a familial mutation. It's an ECAD-Huron, and because it's an ECAD-Huron, the patients are more likely to have lobular breast carcinoma, right? And then these signet ring cell gastric carcinomas. It's not common, but the patients will be young and they will present with lobular breast carcinoma and sometimes these signet ring gastric cell carcinomas. Now, these are terrible, terrible, terrible diseases because counseling these patients, we know that there are something like over 100 different mutations that can happen in CDH1. They all have different presentations, like as to what your risk is going to be of actually developing gastric carcinoma. So when you're counseling these patients, it's a good thing I'm not showing a slide right now. When you're counseling these patients, as far as like genetics, and you're like, well, you have this risk of having infiltrative signet ring gastric carcinoma that will kill you, but it's like anywhere from a 20 to an 80% risk. So do you want a total gastrectomy? Like, what do you do with these patients? You know, this is a real problem right now that we're working on to figure out how we counsel patients that have this known disease. So in this patient, she had lobular breast cancer. She was known to have a CDH1 mutation. They knew she had a family history, so there was high index of suspicion. She had already been tested, and that's why they did these gastric biopsies. They didn't see anything. That's why this slide, even though you don't know this is biopsy number 17. This slide has 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 pieces of tissue on it. There were, I think, 18 total jars with a whole bunch of tissue in each jar. This is the only piece that had any signet ring cell gastric carcinoma in it, okay? And this is a primary gastric carcinoma. So these patients, sometimes, if you don't catch them, they're going to show up with the linitis plastica, the diffuse signet ring gastric carcinoma that's just completely eaten their stomach. So always be careful. Let me show you another scary one, just to scare you. Signet ring cells are scary for GI pathologists. So you just need to be aware that they can be there. So this is one that my colleague, Dr. Gastrin, showed us yesterday at Consensus Conference. Let me see. So low power, right? You're looking at this biopsy and you're like, it looks a little busy. And at low power, I thought it was going to be a gastritis. Sure, right? Because it's blue. Well, okay, I'm not in great focus up there, and I apologize. And so you look at it, and yeah, lymphocytes. More lymphocytes, squished mucosa, lymphocytes. Lymphocytes, busy, you know, the lamina propria just has too much stuff in it. Squished, toothpaste, oxyntic, you know, it's been squished out here. Squishosis is my favorite term for that. And then you get down here, and you're like, whoa, wait, that's not all lymphocytes anymore.
Yep.
Let's see. Whoop. Let's see. Let's see. I can't even see him at this power on this microscope. There we go. Whoop. Doop. So this patient also has a diffuse type gastric carcinoma. Were all those on the screen when I pointed to them? I wasn't looking at the screen. Okay. So it doesn't show up great, but y'all are going to have to trust me. And then, of course, Dr. Gastrin revealed the next biopsy, which was just full of cancer. And this one was just the hard one that he showed to demonstrate to us that you have to be careful with stomach biopsies. And you have to always keep in the back of your mind as a GI pathologist, just because they can be super sneaky. But the CDH1 mutation is just something to keep in the back of your mind. So if you've got a young person and they say she's got breast cancer, it could be metastatic breast cancer. So you got to make sure that it's not just a MET, but you also got to make sure that it's not a primary gastric tumor. And if it is, you have to think about the CDH1, because you might be the person to know about CDH1 and your community clinician may not. You know, it's not that common. So something else to keep in mind when you're looking at slides. And also another boards question, and my handout has some other syndromes that you'll want to memorize for your boards. Okay, and then this will just be a diagnosis and then we're finished. So this one, I don't know what I told you. 62-year-old man with heartburn. So we have what appears to be, well, what I'll tell you was a GE junction or a distal esophagus biopsy. That's what it was called, right? Okay, so somebody stop me when you get to something that you think we should actually do something with. Am I in focus on the screen? Yeah, okay, good. Okay, so that just all looks like reactive cardia.
Yeah.
Okay, people are saying, yeah.
Yeah.
What's diagnosis? Yeah. Yeah, what? What's wrong? It is Barrett's with high-grade dysplasia. Excellent. Why? Okay, hold on. Let's let everyone who may not have had a chance to preview these slides. So here's our nice Barrett's, right? -4 dysplasia, well-oriented, few goblet cells here and there, plenty of lamina propria around them, nuclei are small, localized to the basement membrane, nothing to write home about. Here, very different, right? Here's our non-dysplastic Barrett's. But then you have these guys, right? What's going on there? I mean, they're piled up, like really, really piled up on one another. You've got about 5 nuclei where one needs to be. You have decreased amounts of cytoplasm. You have complex architecture. Again, remember you're back-to-back glands where you don't have the lamina propria in between them. Never a good sign. Same thing over here. Back-to-back glands, piled up nuclei. Same thing over here. This one just got a little mishandled probably during, but this at the surface, right? Lots of mitotic figures at the surface. Piled up large nuclei, apoptotic debris. So this is a high-grade Barrett's case, yes?
Yes.
Could even be worse, possibly. You know, you'd want to, but what I have on this slide is definitely a high-grade Barrett's. Even this stuff here that looks much more bland. It's back-to-back, and those nuclei aren't normal cardia nuclei, right? They're not normal esophageal nuclei. They aren't the normal cells that you see in low-grade dysplasia. So all of this is a high-grade Barrett's pattern. So diagnostic criteria for high-grade Barrett's, your architectural complexity, so you can see cribriforming, back-to-back glands, budding, your cytologic atypia, so you want to see loss of polarity, you want to see bigger nuclei, you can see nucleoli. Once it starts to progress to a more invasive component. What else? You can see inflammation. You can see mitotic figures at the surface. You really shouldn't see mitotic figures at the surface and say just a low-grade Barrett's. So this is a high-grade Barrett's esophagus. These are the ones you want to catch because these are the ones that we know that we actually have data to show that if we can catch these patients with high-grade Barrett's before it progresses to an invasive adenocarcinoma, we can actually have disease-specific survival, like prolonged disease-specific survival. So these are the patients that it's super important to make sure we diagnose correctly. And if you ever have a question about a Barrett's case, it's very easy just to send it out to somebody and say, hey, I think this is high-grade Barrett's. Do you agree? In fact, the American Gastroenterology Association recommends that if you're going to do Barrett's dysplasia, you send it out to a quote-unquote GI path expert or have it reviewed by a GI path expert. It could be at your center. The same thing here, really big cells. Let's see, this one was tricky because it only got up to the surface very focally because of the way it had been embedded. But again, mitotic figure right up there, piled up nuclei, another mitotic figure. And this one even has some inflammation. And so you may entertain the thought, could this all be reactive? And the answer is no. Much too much for reactive. It's just too much. As one of my attendings at WashU used to say, too much. You have all this apoptotic debris. You have more apoptotic debris. You have tons of mitotic figures. The nuclei are big and dark and rounded, and you have this weird architecture back to back to back to back glands. So always think about high-grade dysplasia when you see that kind of architecture and that kind of cytologic atypia. And to me, it sticks out at low power, right? Like this, I barely even notice because it's so benign looking at the surface. This, we're at 4x. This really grabs my attention, and high-grade dysplasia should really grab your attention at low power because the cells are going to be very atypical. The cytology, they're going to be bigger, they're going to be darker, and the architecture is going to be weird. So it should catch your eyes at low power. All right, that looks like all I have time for today. We're 5 minutes over. Happy to take any questions if y'all have questions about any of the cases.
How do you rule out intramucosal in this case?
I know, and I brought one that we could go through. But so intramucosal carcinoma, sometimes it's difficult to be able to tell. But things that make me start to think about intramucosal carcinoma, it's going to be more of the budding, seeing a single cell that doesn't appear to be attached to any particular gland. If you start to see necrosis within the glands, so almost like almost like what you would see in the colon as a crypt abscess, but up here you would see within the glands that kind of dirty necrosis, the neutrophils and the apoptotic debris, you worry that there's an associated invasive carcinoma with that Barrett's that you may just not be sampled on your slide. So, but intramucosal carcinoma, high-grade dysplasia, that is, you could ask 5 different GI pathologists and you might get 2 on one side and 3 on the other. So the important thing is to be able to tell your clinician that we have at least high-grade dysplasia. Like, I know this is bad. I know it's at least high-grade. Perhaps there's another component, especially if they've only given you one biopsy. They probably need to go back. Like if they weren't expecting it, if they just thought, oh, this just looks like plain Jane Barrett's, it could be that they need to go back and do more biopsies to be able to rule out something else. So, all right. So I have these. I think I probably have enough for everybody. And then Rafat or someone can scan and email it to